Well, good afternoon, everybody, and welcome. We're glad to have you here, both in person for a small number and online for many more. So it's my distinct pleasure today to introduce Tanya Dorff, who's our visiting Rifkin professor this year. This is the third annual Robert Rifkin visiting professorship, and we're pleased to have her there. For those that have remember walking down memory lane with me, our first visiting professor was Samuel Denmead, who came in 2018. From Johns Hopkins. We had Meg O'Brien from the American Cancer Society in 2019. Last year, John Gore visited us from the University of Washington. We're delighted to again add Tanya's name to that list this year. Dr. Dorff is an associate clinical professor in the Department of Medical Oncology and Therapeutic Research at the City of Hope. She is a widely recognized expert in the field of genital urinary oncology. She's specifically known for her work in prostate cancer, and today we'll be talking about immunotherapy, specifically CAR-T and other therapies with regard to metastatic castration-resistant prostate cancer. We're really excited for this talk, and I'm going to present Dr. Dorff with a plaque to commemorate her presentation today and being with us for this visiting professorship, and add her name to the list as I mentioned before. So without any further ado, please welcome Dr. Dorff.
Thank you so much for the honor and privilege of coming out here and sharing with you some of our work in immunotherapy for prostate cancer. It's been so much fun getting to meet some of you, and for anyone who has questions after the presentation or wants to reach out in the future, I'm sure we can be connected. These are my conflict of interests. And Saul Priceman is the PhD who created our CAR-T that I'll be talking about. So cellular immunotherapy is not new for prostate cancer. We've had sipuleucel T for more than a decade, and some clinicians have stopped using it, but I'm still a believer. Dendritic cells maybe aren't the most powerful effector cells in the immune system, but over and over again, through real world experiences, through the PROCEED registry, we see the survival benefit. And there's mechanistic support to explain why immunotherapy can help in castrate-resistant prostate cancer, although certainly many other agents have tried and failed. But we obviously need something much more powerful, and that's where we turn to our T cells. So we'll be looking at two different strategies, both CAR-T cell therapy for prostate cancer as well as BiTE antibody therapy. And we're actually studying a range of different targets, including PSCA, which is the CAR-T that's created in our own facility at City of Hope, PSMA, which we're working with an industry collaborator, and then I'll show you some of UPenn's data, the T-Munity story. And then we've just opened the KLK targeted CAR-T with Janssen. Unfortunately, they didn't authorize me to share any slides with you today, so I won't be saying much about it. But KLK2 is an interesting target. KLK3 is PSA, which is secreted, but KLK2 stays bound to the membrane, but clearly very widely expressed on prostate. We also have an actinium-225 KLK2 radiopharmaceutical, so clearly this is a target of increasing interest. So maybe in the future, we'll get to share more about that. We're about to luke our first patient and treat the first patient on the phase 1 first in human KLK CAR-T, which is pretty exciting. Then also the bispecific T-cell engaging antibodies. We've been collaborating primarily with Amgen on those efforts. So we'll talk about those a bit. So why did we choose prostate stem cell antigen? This was discovered in Owen Whitty's lab at UCLA. It's highly expressed in prostate cancer and membrane bound, so it has good characteristics. It is regulated by androgen receptor, and yet in castration resistance, it's strongly overexpressed, similar to PSMA. And really, one thing that is great about this target is that it's highly expressed in pancreatic and bladder cancer, which means that by developing one CAR-T, we'll potentially be able to target 3 different malignancies. Looking at normal tissue expression, on the top is PSCA. The light blue bar is prostate. You can see modest expression in prostate. The dark blue is gastrointestinal, so a bit more GI expression of PSMA than PSCA, more CNS expression of PSMA. But the big difference for PSCA is bladder. This is the orange bar, and that has clinically manifested as an on-target off-tumor toxicity that we've seen with the CAR-T. So our CAR-T uses a 4-1BB co-stimulatory domain. Dr. Preisman was hoping that would help make it require a higher level of expression before activating and might help restrict the toxicity. We don't have a kill switch. We use standard lentiviral transfection and standard selection and expansion protocols. So importantly, since prostate cancer really tends to spread to bone, we had to show that the CAR-T can traffic into the bone. And so this was shown using a mouse model. And then Dr. Preisman did look at CD28 versus 4-1BB. You can see in this third row, this is the CD28. There's some effect, but we get better anti-tumor effect using the 4-1BB. So we designed the phase 1 first-in-human trial to start with T cells alone at 100 million, which is considered to be a reasonable dose. And then we wanted to add in the second cohort here, the preconditioning, or what's called in hematologic malignancies, lymphodepletion chemotherapy. And we based that decision in part on what had happened at Penn, where they escalated the dose first and then added in the lymphodepletion and had some toxicity. So our plan was then to escalate to 300 and 600 million once we had already integrated the preconditioning chemo. So our trial starts for patients with screening on archival tissue for PSCA expression. There's no standard CLIA certified assay, so we had to go through multiple antibodies, and we still don't have really great optimization in bone. But we feel like for a phase 1 first-in-human novel target, it was reasonable to try to do some due diligence and select patients, or at least exclude patients who didn't seem to have any PSCA expression. They're not doing that in the PSMA trials. We have about a 14 to 21 day turnaround time for manufacturing our T cells on campus. During that time, we finished screening, including an on-study biopsy, which is paired at day 28 with a post-treatment biopsy, which is allowing us to learn a lot. We also do standard imaging, but are doing a special protocol using a target bone lesion and an MRI pre and post to see if we can look at objective responses in bone, which would be really helpful. Patients are admitted for lymphodepletion chemo, cyclophosphamide fludarabine, days -543, and then they get the T cells on day 0. And day 28 is really our big day to determine did this work or not. They get all their assessments repeated. So in our very first cohort, without the preparatory chemo, we actually did have cytokine release, indicating that the T cells had some activity in and of themselves and saw a 42% PSA decline in this case. You can see it corresponds exactly with the CAR T cell spiking in the blood and the CRP, reflecting the IL-6. He actually ended up requiring tocilizumab, and his wife believes the toci is why he stopped responding, but we know from heme malignancies, toci doesn't tend to turn off the anti-tumor response. And really what I think explains why it was transient is there was a lack of persistence. You can see the T cell spike, but just bottom right back out. So before we started the trial, there was actually a question in solid tumor CAR T circles about whether lymphodepletion is necessary. It makes a lot of sense in heme malignancies, but what was it actually doing in solid tumors? So now in the lab, it's really been established that you need the cyclophosphamide and probably the fludarabine. It does something to the tumor microenvironment that allows the CAR T cells to get in and do a better job. So you can see here the CAR T by itself not curing any of the mice with the xenograft prostate cancer, but with cyclophosphamide getting about a 50% cure rate. Very interesting. Those same mice, when re-challenged, had some memory and were able to reject new engraftment of tumor. So really profoundly changing the immune activation by adding the cyclophosphamide. But thinking about that first patient's transient response, we actually learned something from those on-study biopsies. He had lymph node only disease, So we wouldn't expect neuroendocrine differentiation, and yet on his on-study biopsy, he had it. So if you look at the immunohistochemistry on the left, there was still PSCA staining. So we figured, maybe there are two components to his cancer, because neuroendocrine is not known to express PSCA, but frankly, we maybe don't fully understand neuroendocrine prostate cancer, right? So we opted to go ahead and treat him. But you can see his post-treatment day 28 scans. The cancer is just exploding, and it's now fully neuroendocrine transformed on biopsy with a Ki-67 more than 90%. So I think tumor heterogeneity is something that's unique to solid tumors, and much less prevalent among heme malignancies that we're going to have to grapple with. So Dr. Kreisman and I have a lot of conversations about dual targeting being a necessary strategy, because I think probably a lot of our patients with advanced prostate cancer have a mixed population, some that's more adeno, some that might be intermediate atypical or aggressive variant, and some that's frankly neuroendocrine. So when we added lymphodepletion, we saw a much more dramatic response in the very first patient, which was very gratifying. So this gentleman developed a pancreatic mass, which I was worried was a new primary, but on biopsy, it was actually still prostate adeno. And so you can see his tumor here with the stent. He received the lymphodepletion and had a little drop in PSA, but then it ticked right back up. And when we gave the PSCA CAR-T, you can see a very nice 95% drop in PSA, corresponding eradication of the soft tissue mass in the pancreas. And on the bone scan, there's clearly less uptake. I know they're not really reliable, but there's clearly less uptake in that humerus and femur lesion. So the CAT scan, of course, can be very confusing to interpret. The day 28 shows more sclerosis, bigger size, and the radiologist will say, treatment response versus progression, right? So here's where we think the MRI could be informative. So we actually have seen a decrease in size of the tumor in the bone, as well as decreased enhancement on various iterations of the MRI images. So we're collaborating with radiology. We think this could be really helpful because we're so limited by bone progression and bone response, engaging effectiveness of our treatments. But probably the most interesting correlative science that's embedded in the protocol is our collaboration with the Kuhn lab at USC. So this is a CTC platform that's completely unselected, sort of plated out. So we can actually see micro tumors in the circulation. We can see all kinds of different cells. And for our patients on study, when we're getting a bone biopsy, we're trying to get marrow. And this was the patient with the very dramatic radiographic and PSA response, and he had a corresponding CTC response. But the CTC populations in the marrow and the peripheral blood were completely different. So the red is the classic cytokeratin expressing CTC that made up a significant component. And you can see just how many more of these tumor cells were in the marrow than in the circulation. But there was clearly a reduction, whereas in the peripheral blood, we have more of these Vimentin positive, cytokeratin negative cells. People don't really know what these cells are, except they shouldn't be there. And so this kind of platform will allow us to do a lot of discovery. They are working on optimizing PSCA staining, so we'll be able to see whether lack of expression in CTCs is a mechanism of resistance, for instance. Do we see PSCA staining on the CTCs pre-treatment and not post-treatment? So there's a lot that we'll be able to gain from this collaboration. Unfortunately, this patient's response was not as durable as we would have hoped. So this is that same patient at day 90. PSA is now rising. We're still better off than when we started. We actually got FDA approval, so to speak, to give a second dose, but the patient had cystitis. That was our DLT. We think it's on target off tumor because of PSCA expression. And I think in part because of that and personal reasons, he just decided never to get that second dose. But we really think that multiple doses might be necessary. So at our institution, we have a hepatocellular CAR-T targeting AFP, and they're giving doses every 2 weeks until you run out of product, with the option to repeat lymphodepletion every third dose. So that's something that we're thinking about for our next cohort. that maybe we're not going to be able to engineer the T cells in a way to maximize persistence, that we might just need to give multiple doses. Because of a second DLT, when we expanded the 3+3 at the same 100 million level, we had to add a cohort where we reduced the chemotherapy dose because we thought that was contributing to these cases of cystitis, especially since cyclophosphamide is known to potentially do that. So this gentleman was treated in the lower lymphodepletion, but still 100 million CAR T cell dose. And you can see this very interesting kind of disconnect in his response. His PSA keeps going up. His liver clearly is better. And his RECIST score is stable because the 2 target liver lesions they picked shrank by 2%. But clearly there is evidence of anti-tumor effect here, and as well in his bone in the hip. So he had no CRS, no cystitis, and this response. But one thing we were able to show in the post-treatment biopsy of his bone is that there was still PSCA staining. There weren't many cancer cells left in the bone, and we're going to be staining to look that the CAR T got in there. We're going to look to see whether it's exhausted, whether it's being excluded. You know, it's going to help us rationally design next steps forward for the CAR T. But it doesn't look like loss of PSCA expression, at least at day 28, which granted is fairly short term, is the mechanism by which some of the cancer survived. So of course, being a clinical person, I want to look at my patients who respond as opposed to the others who had no evidence of response and try to see if there's anything similar about them. And genomics are of course interesting. The first 2 did have PTEN loss, but the third one didn't. He did have CDK12, which can predict for responsiveness to immunotherapy. He had been on cabo-atezo and the liver lesions had never decreased in size. But he had stabilized on that treatment. But you know, we'll continue to look. These are all very, very heavily pretreated patients. I will say one thing we're seeing on the Poseida PSMA CAR T study where they're treating some patients who are chemo naive is maybe that's a more responsive population. It's just really hard in a phase 1 first in human to not give life-prolonging chemo. So that's been a little bit of a struggle for us, you know, clinically, ethically, and scientifically to all try to pick the right patients. So you saw in the mouse models that cyclophosphamide was clearly necessary in order to get good CAR T activity. When we look at the human cytokine data, we see a similar story. So very flat cytokines, without lymphodepletion in these top 3. And then the first 3 with lymphodepletion, you're seeing just a lot more cytokine activity, including the interferon gamma. And persistence even more so. So the 3 black lines are the no cyclophosphamide preconditioning. The colored lines, you can just clearly see we're getting a better expansion and a better persistence with the use of the lymphodepletion chemo. So toxicities have been manageable, I would say. I mean, our dose-limiting toxicity of cystitis is very hard to manage. It's very symptomatic, not just the hematuria necessitating transfusion, but really just having to urinate every 15 minutes. It's very challenging for patients. Again, we think the cyclophosphamide might have been contributing, and we had started at what is an accepted dose of 500 per meter squared for 3 days, but a lot of CAR T protocols use 300, and so we've backed down to that. And it does seem to be helping in our lower dose chemo 100 million cohort. There was one cystitis event, but it was only grade 2. So definitely better. The cytokine release is different in solid tumors than in heme malignancies, at least in our experience. We haven't had any grade 3 cytokine release. We've given TOSI primarily not for hypotension or hypoxia. We haven't seen that, but just because these are older patients and they get really tired after 3 days of fever and rigors. So yeah, our onset of cytokine release is generally around day 4. Whereas, you know, in heme malignancies, you can see it right after the infusion. And the TOSI, again, being administered really just to support the patients. But the cystitis hits a little bit later. beyond the sort of peak of the CAR-T. And it does seem like maybe there's going to be an association with CRS, but we'll have to have more data to really determine that. In this patient, it resolved spontaneously, although it took 1 to 2 weeks. In the 3+3 kind of expanded part, this was a very severe cystitis. So we actually had our urologist try intravesical therapy that is used for other forms of cystitis with lidocaine, Benadryl. They use heparin, but we didn't do that for our patients because of the hematuria, but apparently that's also soothing. Intravesical steroids, but it didn't really seem to help. And so we ended up having to use high-dose IV steroids, which did help, but then he was, between the profound immunosuppression that we were getting with the higher dose lymphodepletion, he ended up with CMV viremia, even though he was CMV negative at the outset, and these like horrible infectious complications. He's still alive. I saw him last week, about 6 months out from CAR-T. But the cystitis was really a major dose-limiting toxicity. So we've hit on some of the challenges in translating this blockbuster heme malignancy treatment into solid tumors, the heterogeneity, the on-tumor, off-target, off-tumor toxicities. But there's a lot more going on in the solid microenvironment that we have to contend with and perhaps overcome to get these wonderful durable remissions that we're aiming for. So at UPenn, they were studying a TGF-beta dominant negative construct because of the negative impacts of TGF-beta on T-cell maturation, proliferation, differentiation, persistence. There are various ways that we're looking to overcome that. And homing to tumor, there's increasing literature about radiation to a tumor site with the checkpoint inhibitors, which the heme folks really question. We're trying to implement a new cohort where we radiate one spot and then give the CAR-T based on the preclinical data, which really show we increase cure in the mice. And the heme malignancy folks are just like, well, why don't you have to radiate all the sites? So that whether abscopal effect really exists, who knows? But at least our preclinical models are suggesting that that may be a fruitful direction. And then with prostate cancer, the myeloid-derived suppressor cells are just such a huge component, I think, of why immunotherapy has struggled. And so one of our colleagues is developing a STAT3 inhibitor. So once that's available for clinical testing, we think that could be another way. So unlike heme malignancies where you can give the one dose of CAR-T and really achieve big durable remissions, it's going to take more in the solid tumors. Vivek Narayan was kind enough to share with me the slides that he presented at PCF from their PSMA targeted TGF-beta dominant negative CAR-T experience. So they had 2 cohorts where they escalated the dose of the T cells alone, and they saw fairly minimal activity, although they did have one CRS, and interestingly, it hit right after the infusion, which we haven't seen. But generally speaking, they felt like it wasn't enough just to give the T cells alone. And when they went ahead and added lymphodepletion, which is cohort 3 and -3, the red and purple, you can see higher peaks of the CAR-T, and on the PSA waterfall plot, you start to see some PSA responses. However, they had significant toxicity, and unfortunately, the study was shut down, as I think many of you are aware. The first patient died due to sepsis, but also if you look at the parameters, there was probably macrophage activation, and the second patient who died was macrophage activation. Macrophage activation, I think, is not nearly as well understood and described as cytokine release, right? We all understand IL-6 is cytokine release. That's why we give TOSI. We understand it can then have the neurologic toxicity later on, the ICANS. Macrophage activation, this survey study just asking different centers, how do you even define it? What are your diagnostic criteria for it? Let alone how do you treat it, right? So we did see macrophage activation with the Poseida PSMA, and I was really grateful to have those heme malignancy colleagues to try to understand this. But you'll see the MD Anderson definition is saying a ferritin greater than 10,000. Ferritin to me is definitely key in identifying macrophage activation, but I'm not waiting to 10,000 because I don't know that you can bring the patient back from that level. You can see that some of the definitions include hepatosplenomegaly, definitely liver involvement is an issue. A bone marrow biopsy can be done to look for hemophagocytosis, but in our experience, we've found ferritin to really be the most reliable. And it's not about, for me, the absolute number, but that doubling that kind of tells you that it's about to go off the rails. So the BiTE PSMA CAR-T, we treated the first 4 patients on the trial. They use piggyback modification of the T-cell receptor, so it's a non-viral process, but it's trademarked, and so I don't have all the details. They also use a very distinctive selection process to try to increase the amount of stem-type T-cells, which they believe will persist better, but also might have a different kinetic in terms of when the peak expansion occurs, which they thought could impact toxicity profile. So these were slides that BiTE shared at a industry kind of a conference that they were okay with me sharing. So these are in the public domain. But it's interesting to see very high levels of T-cell spikes, CAR-T spikes, occurring, sometime around 10 days, it looks like. And they're saying little CRS, although there is some CRS definitely. The first patient I treated did fine. He didn't respond, but no toxicity. The second patient had the macrophage activation. And so there was a temporary hold. And all the investigators, we put our heads together and said, how can we make sure this never happens again? And that's where we decided we were just going to track ferritin and CRP every day, every other day, super intensively, and react long before the other symptoms of macrophage activation would occur using toci, steroids, anakinra, because you don't get that IL-1 data, the IL-6 data in real time, but the ferritin in your lab can turn around pretty quickly. The patient who did develop macrophage activation started out, or at least the symptom that he called in with first was uveitis. He had kind of gone blind. And he still refused to come in and let us take care of him, which is part of why I think once the macrophage activation gets too severe, you cannot bring someone back. By the time he came in, ferritin was over 10,000, liver enzymes were very elevated as well in the thousands. So I really think it's that early identification and not waiting for a full diagnostic criteria to be met if we're going to keep the patient safe. So let's look at the BiTE responses because it's actually very encouraging. In terms of PSA on the waterfall plot, you can see one patient a complete PSA response and a couple more beyond 50%. And this is a very small sample size, so very encouraging. The PSMA PET SUVs also are being tracked and showing improvement, which we'll look at radiographically. But one of the patients on the graph is my third patient. When we reopened the study, his PSA dropped from 2,000 to 1,000, but his ferritin started going up and started doubling rapidly. So I gave him steroids, toci, anakinra until that and the liver enzymes turned back down. And so his response might have been abrogated by that. So it's a very fine line in trying to shut down that activation of the myeloid component without shutting down the T cells. I don't think using the kill switch would have been the right thing to do because I think once that component is set off, it's a different activity. It's not that the CAR-Ts are doing ongoing damage. So we didn't use the kill switch, although there was some talk about it. But I was able to give him oral Cytoxin, which I had talked about with UPenn a bit and kind of reinvigorated his response with another PSA decline after that and without reactivating macrophage type symptoms. So I think we're really trying to learn from each and every patient and share with other researchers. So that's why, again, I would love to hear your experiences today or in the future because we owe it to our patients to really learn everything we can from each other. So these are some of the PET responses. You can see the PSMA PET very hot in this pelvic bone and then nice and cold. I think this is Susan Slovin's patient. They did a biopsy and showed the presence of CD4 and CD8. They haven't yet done the CAR T cell studies to show that there are CAR T cells in there, but they showed lymphocyte infiltration, showed like healing in the bone and absence of tumor to correlate with that radiographic response. So these are real. So CAR T can work for prostate cancer. And that's sort of the conclusion for this segment. I think they're clearly effective, but we have work to do. We have to work out dosing and we have to work out toxicity. So I wonder, given that both Poseida and UPenn saw macrophage activation, and knock on wood, we have not seen it with PSCA, whether PSMA has something to do with that, because PSMA is expressed in vasculature. I don't know, but it's interesting. We don't know what the TGF beta dominant negative aspect of that T cell contributed to toxicity. For our PSCA, I think we can say we have now shown that this is a valid target because we have induced clear anti-tumor response, but cystitis is clearly established as the DLT. So Dr. Preisman now has a mouse that developed cystitis in one of the CAR T preclinical experiments, and that's what we needed. We really needed a preclinical model so we can test different strategies to mitigate the cystitis. That's what's going to help us move our CAR T forward. So we're interested, for instance, in using cold antibody intravesically to see if that would protect, or if anyone has any other thoughts, I'm wide open to it. And then also we're interested in moving into pancreatic cancer and bladder cancer. Regional administration is also intriguing, especially when it comes to bladder. We could use intravesical instillation. And I'll show you one of the reasons I'm excited about regional administration. And then thinking back to that first patient with the neuroendocrine, dual targeting is another direction we're going. So regional infusion has been successful in our glioblastoma CAR T program. It's an IL-13 receptor beta target, and a recum device is installed. So it's sort of like an Ommaya, but different. And the CAR T cells are infused directly into the cerebrospinal fluid. And you can see really nice regression, and this was quite durable. So we have ongoing patients being treated on this protocol. You can see on the timeline they get multiple doses. We also are doing a HER2 targeted CAR T for HER2 expressing cancers with brain metastases, primarily breast. And so regional has its appeal. But as I mentioned, I think dual targeting may be needed for prostate cancer. So we know that there are probably mixed populations of adeno and neuroendocrine at any given time, and whatever treatment we're rendering might affect one population more than the other, which leads to outgrowth. They have distinct targets, so it's unlikely that we're going to find one target that we can make a T cell against that's going to hit both types of tumors. So we're part of a SPORE with UCLA that's really investigating along these lines using CEACAM5 targeting approach. So CEACAM5 has been shown to be highly expressed in prostate cancer, especially neuroendocrine. And CAR T cells have been generated and tested in the lab showing anti-tumor activity. However, toxicity on target, off-tumor toxicity has been daunting. So colitis, hepatitis, pneumonitis. So CEACAM is just expressed too broadly. So how are we getting over that? They're developing inhibitory CARs where using a checkpoint, and you can see they're studying multiple iterations with various checkpoints. If the cell expresses both the CEACAM target and the checkpoint, then that's not a cancer cell and the CAR T will not activate. There's an inhibitory domain that will turn it off, versus a cancer cell presumably won't have the checkpoint, and so the CAR T will be effective against it. So this is a really innovative strategy, I think, very interesting. Preclinically, it looks like it's working. So again, it's going to be an issue of finding the optimal checkpoint, because some cancer cells, I think we've all learned with a PD-L1 experience, can express checkpoints. And so trying to choose the right one so that we're inhibiting the T cell really only at self and not at tumor. So I've talked about CAR-T, and I don't know how many of you watched ESMO online, but there was this cool session of CAR-T versus BiTE, which will win. And I think the CAR-T argument was stronger. I know there are limitations, cost. This is an autologous product, very expensive. They're in the hospital. But there are ways around that. Our RCC program is testing a CRISPR-modified CAR-T that is not autologous. It's off the shelf. And having some interesting positive results, although I can't say too much about that. CAR-NK is another way to get away from autologous production, and that's something that we're just embarking upon in our lung program. But you can't beat the durability of remissions when you put in a living product. And also, it's just such a flexible platform. As you've seen with the inhibitory CAR-T and the dual targeting, you can just do so much with a CAR-T that I think maybe BiTE won't have quite as much flexibility. But we are studying BiTEs because we don't believe in testing just one strategy. Bispecific T-cell engaging antibodies have been approved for ALL, blinatumomab. They do require ongoing administration because as the antibodies bind and get cleared, then there's no reason for T-cells to engage. So the PSMA targeted BiTE has one domain for CD3 to grab the T-cell and one for PSMA to bring it in proximity to the cancer and hope that it will attack. Initially, Amgen had one that required continuous infusion, but AMG 160 was engineered with a half-life extension, so it only needs to be infused every 2 weeks. And I understand you guys will be opening the trial, so welcome. It's been a lot of fun working with this. And then AMG 509 actually has 2 heads for the target and 1 head for CD3. So I don't know if you call it a trite. But it's a different target, it's STEAP1, and that 2-to-1 ratio is something interesting to see whether that will impact the amount of cytokine release as postulated. So these were the results we presented at ESMO last year from AMG 160 from the phase 1 dose escalation where we went all the way from 0.003 up to 0.9. 0.9 was definitely a lot of side effects. So the 0.3 milligram dose is what's being expanded. But you can see in the waterfall plot at these 0.3 higher blue doses, a good PSA response. On the swimmers plot, you can see even at the lower doses, the orange and pink bars, this is the 6-month line, there were definitely a lot of patients with at least stabilization, even if not dramatic responses, going out beyond 6 months. You can see in the table some of the CTC conversion, the RECIST responses, definitely an active treatment. However, more than 90% of patients get cytokine release. So you just have to be ready for it. A quarter of the cytokine release patients are grade 3 and up. Now, a lot of that is actually due to liver enzyme elevation. With this drug, you can go from normal to 1,000 AST ALT overnight, and then it drops right back down. But your hospitalists might get nervous when they see that. But so a lot of the grade 3 was really due to that, and less of it due to hypoxia and hypotension. Although we have used tocilizumab, we have had a patient or 2 go to ICU for hypotension. I think maybe because of the PSMA expression in the gut that we get nausea, vomiting, and diarrhea, especially with those first few doses where they're having most of their cytokine release. And then you do get the dry mouth and taste change, which is on target for PSMA in the salivary glands. So Amgen has developed a number of strategies to mitigate the CRS. So everyone gets dexamethasone pre-med in the first cycle, and then you can taper it off. Not everyone is able to come off the dex right away in cycle 2. There's a smaller dose that's given first before the target full dose is given on the second dose to try to get some of the CRS out of the way. And they're really working hard to make this something manageable and scalable to roll out to a broader patient population. So the phase 3 is actually anticipated to open up either later this year or next year. AMG 509 targets STEAP1, which is 6 transmembrane antigen of the prostate, something like that. And in preparing for this, I hadn't really looked into STEAP1 as a target, but there had actually been an antibody drug conjugate targeting STEAP1, this DSTP, with an MMAE payload. So that's very similar to enfortumab vedotin. And they did see PSA responses when the dose was greater than 2 mg/kg, as well as some objective responses and CTC conversions. So STEAP1 seems like a valid target. with this different kind of a platform. They did see hyperglycemia, so that makes me think that's an MMAE thing, because we see that with enfortumab. But they also saw transaminitis, which we see maybe because of this little bit of liver expression over here in STEAP1, but largely STEAP1 heavily expressed in prostate cancer and pretty low, moderate levels in other places. So STEAP1's a good target. I unfortunately can't share too much with you about AMG 509. Data haven't been presented yet, but we treated patients at some of the lower doses, and some of my patients stayed on longer than 6 months with stabilization. So I've been very pleased. I saw less cytokine release, but that my patients weren't getting some of the higher doses. So, you know, that I would say is not yet, we can't really determine whether that 2-to-1 is making a difference there or the target. So BiTEs are really being studied broadly now for solid tumors. A lot of BiTEs are dual IO kind of checkpoint targets, but more and more I think they're also including solid tumor type antigens. So a BiTE platform is clearly effective. Will we see durable remissions is a question. There is a lot of toxicity, so you have to be prepared, and it's going to take a fair amount of education and training, I would say, to roll out to community practices. Also, anti-drug antibodies. So about a third of patients with AMG 160 make anti-drug antibodies. Some of them are shown to be neutralizing or impact PK. Interestingly, some of the patients with ADA still benefit. Their PSAs stay down and they continue to respond, while others, you see that PSA turn around. So there's a lot to try to learn and understand about the ADA, but clearly a platform that's worth studying further. So I have no sense of the time, but I wanted to just take a moment to thank the patients who've been so brave to go on these phase 1 first-in-human journeys with me. And now some of them are even donating to expand our CAR-T study to these additional cohorts, the multi-dose, the radiation. And it just takes a huge team to do this. And without a good clinical mentor from heme malignancy world like Steve Foreman, we wouldn't have been able to keep our patients safe and do this in the best possible way. And without the basic science, we wouldn't be learning from every single patient and really streamlining, making efficient our move forward in testing the right kinds of next strategies. So thank you again for the opportunity, and I look forward to some questions.
Let's see if this mic works. I'm going to stand all the way over here. Dr. Dorff, there's a fantastic talk. Thank you so much. I think there's a great amount of excitement with CAR-T therapy in oncology in general, I'd say even in popular press. And to hear, I think that's the best summation I've heard about the efforts in prostate cancer. So it's really great to hear. So we've got a group here in the hall, and I think there are 50 or 60 people online as well. So we have some time for questions. We've got about 15 minutes, so perfectly timed. So what I'll do is see if there's any questions in the room first. There's one hand here. Go ahead.
So you mentioned in one of your studies this idea of macrophage activation being a DLT code. Can you tell me a little bit about what's being done in this space, prostate cancer, that you may be related to or know of, to appreciate the role of macrophages in the CAR-T response, given this, activation? I mean, what's the mechanism there driving that response in some patients and some not?
And would you mind repeating the question just for the folks online?
Yeah, so that's a great question. First and foremost, what's being done to understand and appreciate the role of the macrophages in all this, and what is the mechanism for macrophage activation? As I mentioned, I mean, the papers that are out there are like polling expert thought leaders. There's not so much data. We do know IL-1 is a big part of it, which is why we use anakinra. And my poor understanding of it is that there's just too much cytokine storm because it is associated with CRS. You don't really see it in the absence of CRS. And then the cytokines just take themselves away and activate this myeloid component outside of the T cell activation that you want to have happen. And then that component's taking off and driving itself. That's, again, not scientifically proven, but you're absolutely right. And I should pose that to Poseida. They're getting some tissue and a lot of blood samples, and they should be studying it. And so if you know a good lab that's interested in macrophages, I think part of the problem is CAR-T is being done by people who are much more interested in lymphocytes, right? But we should be studying more what is the role of the whole myeloid component, macrophages, in helping or hurting our ability to move immunotherapy forward.
Any more questions in the room here? Laura?
Along the same lines, it was both with the T-cell B-cell HLA-10, was it, they both the TGF-beta dominant negative?
They were both PSMA targeted. One was the UPenn's TGF-beta dominant negative. The macrophage activation was seen in both that and in the Poseida, which is not TGF-beta. It's piggyback modified and stem cell selected.
And for our folks online, I think if you unmute yourself and speak, we can hear your question. Just have to have one person do it at a time. Any questions online?
Tom, this is Mike Lode. Can you hear me okay?
The voice of Mike Lode, loud and clear. Great. I just would note that Mike Lode, my mentor, was the founding holder of the Robert Rifkin Chair. So Mike, it is great to hear you. We can't see you, but great to hear you.
Well, it's lovely to hear Tanya. You and I have both co-published with her, and it's great. Tom, you might expand on the question a little bit just with the history, but I was thinking about the metronomic cyclophosphamide, and it's being tried with Pembro in ovarian cancer. I found an article while Tanya was talking, and the question of if you gave lower doses preparatory regimen, it suppresses T regulatory cells. Maybe you could get away from some of the hemorrhagic cystitis type things. It'd be interesting to try in that mouse model, for example. I don't know enough about its ability to suppress anything other than T regs, but it might be something that you guys could discuss.
Yeah, that's a great point. We actually were interested, and I just haven't really had the bandwidth, in just doing a study of oral metronomic Cytoxan, comparing it to IV Cytoxan, and looking at modulation of the tumor microenvironment and impact on Tregs and other aspects of immune activation. Because, we simply borrowed lymphodepletion from heme malignancy, but we don't know what's the optimal way to do it in a solid tumor. And I do think maybe metronomic Cytoxan would be a better way, but it would take a study of that. And, I probably need to bounce it off some patient advocates, because at first I was like really gung-ho, I'll write this trial, they'll either get metronomic Cytoxan, which has some track record in the literature of anti-prostate cancer effect, right? There's published response rates. Or they'll get IV, and then I'll just measure all these immune parameters. I'm like, sort of what's in it for them? There's a lot in it for us, but you're right, maybe we could do it in the mice. That was a really helpful suggestion there. Although, how chemo is dosed in mice, I think is a little bit hard to translate to how it is dosed in humans. But yeah, giving it afterwards, I think is interesting. I don't know that it's only Tregs. I really think it does something also in the broader tumor microenvironment, but there's a lot we need to learn about it.
Great question, Mike. Thanks so much. Any other questions online?
Yeah, can I? This is Mercedes.
Yes,
Hi.
go ahead.
Can you hear me?
Yes, we can. Please go ahead. Thank you.
So one of the big differences between mouse and human is the human CD4 cells make a lot of interleukin-6, and that could be variable depending on the people. And mouse CD4 cells don't make interleukin-6. So that's, I think, potentially one of the reasons why it's hard to get the CSR in mice. But human CD4 cells don't make interleukin-6. So I wonder if you control the relative fraction of CD4 and CD8, and whether this could be something interesting. Primarily, again, to minimize, I think, the levels of interleukin-6 that you are going to get with the T cells, the CAR-T.
So thank you. That's an interesting thought about differential IL-6 production. I know that Dr. Priceman has a very special mouse model with a I want to say, a humanized immune system so that we can try to mimic better what's going to happen with the human xenografts and the CAR-Ts. But I wonder if there's a way to answer your question within human biospecimens or other ways to study that. So thank you. I'll talk that over with our T-cell team.
Yeah, and also the ratio of CD4, CD8, because that could make a big difference too. And I know that in some cases, are you using both? For the CAR-T, you're using both CD4 and CD8 probably, right?
I don't know the answer off the top of my head. I'm so sorry.
All right, thank you.
I know we based the 100 million on CAR positive, but I don't remember offhand whether there's a fraction of CD4 versus CD8.
Okay.
Thanks very much. Any more questions online? Okay, we'll go back to the room. Any more questions in the room? One right here.
This is very interesting. A lot of what we're using in the context of our T-cells is based on histological malignancies. Is there an effort to take 2-3 steps back and start over with the idea that we're targeting solid tumors versus histological malignancies, so that we redefine a little bit what, how many CAR T-cells we're giving, what we need to give before as we lead in. What's that look like? I'm not in the CAR T-cell field, but I just would like to hear a little bit about what we've done in that instead of trying to repurpose everything for solid tumors.
You want to recap that question too, sorry.
The question was about the fact that we are borrowing so much of what we're doing from heme malignancies and whether there needs to be a step back and more preclinical work to understand what is needed for solid tumors in terms of dosing and maybe preparatory chemo. So yeah, Owen Woody said to me at one of our SPORE meetings a couple years ago, do we really need lymphodepletion, right? And we did design our protocol, and so did UPenn, to test the T cells on their own. But now I think with the work that Saul has done in his lab, it's pretty clear you do need it. It just might be for different reasons. And I do think taking some steps back and understanding more about what is the cyclophosphamide doing, and also the radiation. Like I mentioned, the heme malignancy people are like, well, wouldn't you have to radiate all the tumors? And yet we see it in some instances where radiation to one area followed by immunotherapy has more broad effects. So what has to happen to the tumor cells so that they're more visible, or to the tumor microenvironment so that they're not excluded? There are physical barriers. I think I didn't talk about everything on the slide. That's that picture. It'll be coming out in Clinical Cancer Research. It's a review article that we published together with UPenn about CAR-T for prostate. But there are some real daunting stromal factors that may impact T-cell tracking. So is the cyclophosphamide doing something to that, or is the radiation able to do something to that? And I always think the science has to drive us. So, we've been talking about opening further cohorts, but I keep going back to Saul and saying, hey, you have those post-biopsy samples. What are you seeing? Are you seeing that the CAR T cells are exhausted? Are they getting in? Because I really think if we don't go back and ask those basic questions, then we design trials that are likely to fail because we just put stuff together that we think will work, but we don't. We need to know what the science, what the human experience is showing us. So yeah, I think you're completely right. And we are trying to do that. We're trying to view each solid tumor as something unique, but also still try to learn from what's happening in the other solid tumors.
Is there another question in the back row?
Actually, the prostate stem cell antigen, is there an importance between archival primary and metastatic sites?
Yeah, so we're often, the question was about concordance of PSCA expression between the archival primary and the metastatic sites. We are seeing good concordance. I have yet to see someone where the on-study biopsy is negative for PSCA because we used the prostatectomy from 5 or 10 years ago to check for that initial pre-screen. So we felt like it was important to do that due diligence, but as I mentioned, the PSMA trials are not doing that, and we know PSMA is not 100% expressed. So kind of interesting that because it's a more validated target, they're doing unselected. So our assay, you know, I would hate to exclude someone because it's staying negative when it's not a CLIA certified assay, but we are. So if the prostate primary didn't have it, some patients have said, well, why don't I get a metastatic biopsy? Let's see, you know, does my cancer now have it? But in those rare cases, we haven't seen it in the MET either. So there does seem to be good concordance.
We've had a great discussion, a great question and answer period here. I'm just going to flip back to online one more time to see if there's any additional questions there. We got one more in the room here. This will be our last question. Thank you.
That your first patient that you were talking about that had the neuroendocrine kind of growth after treatment, do you think that that got worse because of the CAR T cells?
So the question is whether the neuroendocrine outgrowth in that first patient was made worse by the CAR T cell. I mean, there is talk about hyperprogression in the world of immunotherapy and solid tumors, and yet I'm not sure I've ever seen it. I think the neuroendocrine cases just grow logarithmically anyway, because I have enough of them in my clinic now where they're fine one day and a week later they're symptomatic and their cancers are just growing really quickly. So I don't think the CAR T did anything. You could ask whether something like lymphodepletion could be harmful, because in suppressing the immune system, whether then whatever immune surveillance might have been occurring in the neuroendocrine component is released and the tumor is unleashed, but that guy didn't have lymphodepletion. So I don't know, I think his kinetics fit with what I see outside of the CAR T trial, but you know, patients ask that too, and it's really heartbreaking because first we want to do no harm, and these are really new. We don't know how things are going to go, and that's a big part of the experience of participating in these types of trials is engaging with the patients. But the patients are so grateful. I had one patient fly in from Brazil asking to be on the study, and his daughter just said, "Thank you for doing this. Like, patients everywhere need this hope." So they're invested. They're willing to do this, and sometimes they ask those tough questions on the back end. So all we can do is be as honest as possible. That patient I treated after my patient had died of macrophage activation, he knew that patient had died, and we talked about it very frankly, and we talked about the ways we were going to keep him safe. And so I believe in full transparency and really, you know, supporting our patients so that they can take this journey with us.
Well, with that, I'd just like to say we'd like to thank the Cancer Center for hosting our session today. We're going to start planning for next year's Rifkin Endowed Professorship. And we'd just like to say a sincere thank you, Dr. Dorff, for joining us today, for giving an outstanding talk and really being on the cutting edge of this field. So thank you very much.
Thank you.